I will introduce Dr. Brown here shortly. My name is Dr. Hawkins. I'm the Chief Medical Officer and one of our emergency medicine physicians here at the district and host most of these healthy lifestyle talks. So those of you that have joined before have probably heard this introduction, but today we have Dr. Stacey Brown. He's a graduate of Baylor College of Medicine in Houston, Texas. Completed his family medicine residency at the Ventura County Medical Center before moving to Bishop. And Dr. Brown has been living and treating patients here in Bishop for almost 30 years, up to I think 27 years now. He's familiar with a wide variety of men's health concerns in primary practice, and we're looking forward to hearing what he has to say tonight.
Thanks, Adam. Yeah, almost 30 years, man. That's like, it's quite amazing. So, I didn't know we were up against the presidential debate tonight, but, thank you for logging in. If you don't want to see two men, debating each other, then you can hear about men's health, tonight on our spiel. So I'm going to pull up my slideshow here and we'll go ahead and get started. So give me a sec. All right, good. And we'll do this and we'll do this. All right, so Barb, are we good?
Yes, we are.
Yeah, okay, good. All right. Okay, so Men's Health Month, right? Adam had asked me to do a men's health thing. I haven't done one of these before, but I've done tons of other lectures over the years. And so as you have seen in the past, I kind of take a lighthearted approach at a lot of my lectures and try to get some good audience engagement. So if you have questions along the way, throw them in the chat or live stream, and I will get to them probably at the end. We can do kind of a Q&A session. So yeah, as you know, we've got Men's Health Month, right? June. We're at the end of June right now, but a lot of I gotta click this. Hold on. There we go. A lot of things, we have lots of different months that celebrate different things. And so you're seeing a lot of press kind of out there where little blue ribbons instead of the pink ones for breast cancer awareness. So yeah, great. It's spotlighted men's health issues. We are some of the worst at doing health maintenance in the primary care world, at least. And yep, we are all human beings, regardless of gender, men or women. So yeah, we have some of the same health concerns as other people, and I'll talk about those things like cholesterol, things like high blood pressure, anxiety, depression, problems with diabetes, colon, skin that just ages, or joints that just wear out over time. If we're too skinny or too fat. So those are the same as pretty much everybody else, regardless of gender, whether it's Men's Health Month or not, including some of the bad behaviors that we do, alcohol and smoking and risk-taking and stuff that are specifically us. So here's the everybody stuff, right? Heart disease, that's the #1 killer, right? So lots of men have it in the US, 1 in 3 as far as heart disease. 1 in 4 are going to die from this. So yes, this is probably, one of the major things that we want to focus on as far as heart disease. So you've heard this a million different times. The solutions is to eat better, doing, less bad things like less salt, less fats, more fruits and veggies, treating the things that are before heart disease. Because really, 1 in 4 of us are going to die from this. So this is a high population of concerns that we have. Women, it's going to be less, right? Cancers, same thing. We're breezing through this pretty quickly. 700,000 in men every year, 300,000 die, not as much as heart disease. We got a 1 in 2 lifetime risk. So cancers are big stuff too. I don't want to, forget those. So the good things that we do, you've heard this before, lots of different health maintenance things. Don't do bad stuff like smoking. You want to do better things like diet and exercise. This will help risks for colon cancer. Limit the amount of drinking for stomach cancer, limit the amount of sun exposure that you get for sunscreen, and then do the early prevention and screening, the Cologuards, the colonoscopies, the prostate checks, all those kinds of things. In women, it's less, right? So maybe 1 in 3 lifetime risk, including breast and pelvic tumors. All right. So what do we do for cancer prevention? For men, lots diagnosed again. Oops, I think this is a repeat here. Yep. Colon cancer screening started at age 45. checking your labs, talking to your PCP about getting some of your stuff done. New kid on the block is coronary calcium score for some of the prevention stuff that we do. Lung cancers with low-dose CT imaging. Quick view through diabetes. 15% of all men, more likely if we have a lot of belly fat, we're going to get this even at a lower weight. Again, avoid the bad stuff. Lots of sugar. Try to get more fruits and veggies. Don't get too fat. Exercise. Women, again, less risk of this. So not to belittle these guys, you know, this is something that is real. I do deal with this every day. And we talk about this, and you get hammered with this every day, whether you're men or a woman. So it's real, no doubt. And I don't want to belittle it. But, you know, you hear this so often, we just got to get numb to it. So, yeah, spotlight in men's health. We get the same stuff as everybody else. All right. But, all right, we've got other things. We've got a prostate. We've got testicles. We've got a penis. And we've got testosterone. So, yeah, let's spend some time on the stuff that we see and that we're concerned about as men coming into the primary care office. I'd say that most of the guys come into my office not because they're worried about heart disease or whether they want to stop smoking or cut back on drinking. They're about these 4 things. So let's spend some time really kind of dissecting some stuff that is specific for men's health concerns. So throw up in the chat who your favorite Superman is, whether it's old school Christopher Reeve or Henry Cavill or some of the new guys on the block with Brandon. All right, so let's hit these 4 areas, right? And we'll hit them kind of in some depth too. So let's talk about prostate. 30 million guys suffering from dysfunction of the prostate gland in the US. Lots of cancer in the prostate gland as well this year. 30,000 of us are going to die this year in the US from prostate cancer itself. Remember that the prostate gland kind of sits right below the bladder. It surrounds the tube that goes from the bladder out to the end of the penis called the urethra. It produces fluid. It contributes good things to sperm as it moves through the system during an ejaculation, fuel, antibodies, volume to the sperm. And the prostate gland does get bigger as we age. So, you know, an old professor of mine said, you know, if we all live to be 100, we're going to have a prostate the size of a grapefruit. So yeah, it gets bigger as we age, and it does cause some problems. So every guy that comes in, you know, what do we think when we say prostate gland? They think of this, the dreaded digital rectal exam, right? No one wants to get their prostate checked because this was standard for many, many years. If you came in, you ended up getting the one finger salute. So what is the status of the digital rectal exam now? Because this is our face when we think about, you know, getting a prostate check in the office. So good news, the digital rectal exam has really failed to be a good screening tool for us, especially for prostate cancer, because this is really what we're looking for. Especially in guys that have no symptoms, right? You're a guy that comes in, you're over 50, no symptoms. Digital rectal examination is not super helpful. So it's really not recommended for everyone now, right? Which is great news for us. It does have some utility in some high-risk patients, right? So if you have a dad and an uncle that has prostate cancer, and we're really trying to, you know, kind of drill down and look and see what your risk is, certainly we may end up doing a digital rectal exam. Also, if you have symptoms, right? If you come in and you're like, you know, hey doc, I'm having symptoms that may be related to the prostate, then we are going to potentially do a digital exam, but not everybody's going to get one of these anymore. Super good news for us. So how do we check for prostate cancer, right? If we're not doing the finger wave, what do we do for prostate cancer screening? Because again, well, 30,000 of us are going to die this year from prostate cancer. Family history, right? Ask a good history. Not mom, but, you know, dad or uncles. Hopefully your mom doesn't have a prostate. But family history, is there a strong family history? Are there any worrisome symptoms, right? Do I have blood in the urine? Do I have blood in the ejaculate? Do I feel like I'm sitting on a hot potato all the dang time? Is the stool, because remember the stool passes right by the prostate gland, is the stool flattened on one side, right? Because the prostate is so big pushing into it. So some of the things kind of, you know, to take a look at. Now, not everybody who can't pee easily has prostate cancer, right? But it's some of the symptoms that we ask about as we screen folks for any sort of prostate, cancer or problems. And so, other than the digital rectal examination, is there anything else we can do? Yes. So there's a thing called a PSA. A lot of you guys have heard about it. It's a prostate-specific antigen. It's basically a blood test. It measures the size of the gland. The gland only produces, or the PSA is only produced by the prostate gland, nowhere else in the body. So it's a good marker. A big prostate will produce more PSA. A cancerous prostate will produce more PSA. And so again, looking at all these kinds of things, looking for prostate cancer to try to avoid it, and doing a digital rectal examination if we really think it's needed. You can also do imaging. So the new kid on the block is doing prostate evaluation by MRI, great soft tissue exam. More expensive. Insurance is, difficulty sometimes, but if it looks like we have a high PSA, a lot of the times, instead of just going right to biopsy, we'll do an MRI to take a look and see what the gland looks like on soft tissue imaging. And then maybe we throw an ultrasound up there and take some samples of some areas that may look suspicious, and biopsy those just like you would biopsy anywhere else in the body you're looking for cancer. So PSA, again, non-fasting blood test. A lot of guys will get this with their annual labs, looking at cholesterol and some of the other stuff we just talked about. It's sensitive. So only the prostate gland, puts this together, but it may not be specific just for cancer. So you can imagine if you have a big prostate gland because you're, 102, you may have a high PSA, but it's not necessarily related to having a cancer per se. It's up. The PSA is up in older or larger, or maybe a prostate that has some trauma to it, like you're having a prostatitis or an infection. It can be down with certain supplements and meds. Some of the prostate medications over the counter will actually reduce your PSA. So it's important to take a history and say, hey, doc, I'm taking saw palmetto, because we interpret the PSA a little bit differently if you're on a med for a big prostate. Also in bigger folks, the PSA may be down because of the effects of obesity on the level. Again, if it's high, not necessarily cancer that's going to kill you, all right? Or not necessarily cancer at all. It depends on a lot of different factors. So talk to your provider on the risks and benefits of testing. And if you're going to test, test early and test often so we can get a trend on this. Now, switching gears from prostate cancer, we're talking about just being big. So a big prostate can be a problem. And so you see on the diagram to the right, that prostate sits right under the bladder where you try to get the urine out through the urethra and out to the end of the penis. And so if you have a big prostate, it doesn't just grow outward, it can grow towards the middle. And so it squeezes the urethra where you're trying to pee. So normal age-related increase in the size of the prostate. We get older, the thing gets bigger. It's harder to get urine out past that kind of blockage. So you get some certain symptoms. So some of the symptoms you may get is you come up to the urinal, and you want to start, and it's hesitating. You're just waiting for that stream to go ahead and start. That's called hesitancy. Dribbling, you want to stop the flow. You think you're done. Oh, nope, here comes a little bit more. You shake. Wait, oh, here comes a little bit more. That's called dribbling. You just kind of keeps dribbling onwards. The stream may be weak. That's a no-brainer, right? It's just couldn't compress. So there's a weak stream when you urinate. And a sense of kind of incomplete emptying. You're like, God, I was just at the urinal like 20 minutes ago. I thought I emptied the bladder, but I guess there's more that's there. You just can't empty all the way anymore. And also frequent emptying. So again, every 15 minutes, like I only put out 2 or 3 teaspoons. So the urine just can't empty all the way out of that bladder past that enlarged prostate. And also nighttime urination, right? You got to get up, 2 or 3 times a night. And I make this analogy to my patients all the time. Like, think of the bladder as a sink, and like in your kitchen or your bathroom. The prostate gland is like this wrench on the outflow from the sink. And if that wrench is squeezing, it's not going to empty the sink very well when you fill the sink up to shave. So it's just an obstruction to the flow outside from the bladder to the outside. Okay, now that you know the pathology here, you can kind of figure out, all right, what kind of treatments can we do? So limit the amount of urine that you're going to produce that you have to clear. So maybe if you're getting up at night 3 times a night to pee, limit the amount of drinking that you're doing, especially caffeine or alcohol, before you go to bed. Less urine production, less you have to pass through the system. You can do some more over-the-counter supplements. I mentioned one, saw palmetto is one out of very many. medications that are out there. Here's a, kind of a scattering of them. Super beta prostate is one, and you've got all these different sterols. They basically will do a couple of different things, including trying to shrink the prostate away from the urethra or try to help flow one way or the other. Prescriptions meds, right? We've heard of Flomax, right? For years we had that. That helps to basically unclamp the wrench that is squeezing the bottom of the outflow from the sink. So if you can kind of get rid of that obstruction, you'll have a better flow. That's why they call it Flomax. If those pills don't seem to work at shrinking the prostate or maybe like helping the flow out of the prostate, there's different things you can do other than surgery. You can do self-catheterization, where there's a little catheter that you slip up there, empty the bladder, a couple of times a day because you can't tolerate the medications or you have an allergy to them. Surgery, of course, there's the old Roto-Rooter that, we had for many, many years. You basically kind of reach up and kind of wallow out some of the prostate growth of the around the urethra to try to get the flow better. And here's a diagram of that, usually done in the operating room to control bleeding, and you kind of get a little bit of a bigger opening to get the urine out of the bladder past the prostate. But there's other kinds of things you can do. It doesn't have to be surgical anymore. You can get up there with thermal cautery, heat, laser, anything that will kind of give you a better flow out of the prostate gland. And there's a new one called Urolift, which I call the staple gun. And basically you run these little staples, these little kind of flexible things up through the catheter, and you kind of pull the urethra or the prostate away from the urethra. These things just kind of stay there and kind of help open up the flow. So again, all of these kinds of different treatments, you can talk to your PCP, your primary care provider, or a urologist who specializes in the kind of the outflow tract here in men about these kinds of things if it looks like you suffer from this malady. All right, here's the staples kind of pulling that prostate kind of like open again. All right, that's prostate. Now let's go to testicles, right? That's number 2 on the hot list here for Men's Health Month. Okay, all of us have seen, the testicles on the trucks, right? So I was looking online and I saw a couple other ones that are quite funny about this. Number 1, testicles on the baby scooter. All right, that was a newbie for me. And then also testicles on this hopped up Prius. Now I own a Prius, it's like 2005. And I thought I drove mine everywhere, but this guy has little fuzzy dice hanging instead of the testicles on the back of the truck. So that was our introduction to testicles. What do they do? Well, let's talk about where they come from first. And this kind of explains a few things that can go wrong with testicles. The developmental pathway when you're in utero is a very specific pathway of the testicles. They start in the abdomen. And in women, they just kind of stay in the abdomen. That's why the ovaries are kind of like intra-abdominal. They're in the belly. So if you think about Route 66, it's kind of the developmental pathway of the testicles. The tissue starts way up in, Chicago and like in Missouri, right? So that's where they start. During development before you're born, they kind of migrate downwards to the bottom of the abdominal wall. This would be like Oklahoma City on Route 66. Then they kind of slide through the midline of the body and through the muscle layers, because it's got to get out of the abdominal wall somehow. And so let's say that that's Albuquerque, right? We're sliding through the muscle layers, Route 66 through Albuquerque. And then they end up in the scrotum where they kind of like end. And I hate to say that we're at the end of the line, like we're in the scrotum here in Santa Monica in LA, but maybe the analogy fits. So they drag their blood supply and their nerves with them. Right. So as they develop, the ovaries stay up in the abdomen, but the testicles drag the nerves and the blood supply with them. And this has a factor to it. Right. So it also explains that, when you get testicular trauma, if you get, an aggressive nut tap or you get kicked in the nuts, you feel it where? Way up in the abdomen in your solar plexus. And that's because the nerves are way up in the abdomen that way. So the testicle can get stuck along the way. So here's the normal Route 66 pathway on the testis. Starts in the belly, goes down, gets through the abdominal wall, and ends up in the scrotum. But if it looks like it gets stuck along the way, you can have something called an undescended testicle. That's why when we do newborn examinations, we're always looking to make sure the testicles are down in the scrotum. And they can get stuck anywhere along the way. So if you have a baby where you can't find the testicle and scrotum, you got to figure out where it got stuck. Did it get stuck in Albuquerque? Did it get stuck in Oklahoma City? Or is it way back up in Chicago? So those things can kind of go wrong. And we want to treat that and identify it early, because if the testes don't end up in the scrotum, there's a higher chance of testicular cancer as you get it to be an adult. Undescended testicle stuck along the way. And it also explains why we get hernias, right? So if it looks like the testicle is sliding down to its, final resting place in the scrotum, it's got to drag its artery and its vein and its nerve supply with them. So there's now a virtual space going through the abdominal wall, and that can kind of widen over time, and you can get a little bit of some intestine or some fluid or something that kind of bulges through that. And guess what? That's a hernia, right? So now you know how hernias develop in a lot of men is that they're following that Route 66 pathway. It's just that it's a little bit wider now. It allows too many things going through there. All right. Other bad things can happen to the testicles other than just getting stuck along the way. So you remember, here's the testicles, right? You've got the testicle down in the scrotum. You've got the epididymis, the little backpack that sits on the back. You've got the vas deferens that kind of is a tube that comes up and around and ends up into the prostate gland that carries the sperm to the prostate. The prostate adds, as you heard, extra fuel and immunoglobulins and other stuff to it before you ejaculate. So you can get inflammation or infection in the system, right? If it looks like this is a contiguous system, you can get something that can directly affect the testicle, like mumps. It's hard to find mumps nowadays, but sometimes it has a little bit of a resurgence in people who are maybe under-vaccinated. You can get an infection backwards from the penis backwards up to the epididymis, like a sexually transmitted infection. Chlamydia is a possibility there too. So you can get some problems with infection or inflammation in that testicle. Luckily, most of those things are treatable. You can get trauma, right? Direct trauma, like we talked about, the overaggressive nut tap, or a twisting, right? So a twisting testicle, since you know that it has its blood supply that dragged along with it, if this thing spins around its axis, this little testicle kind of can lose its blood supply. And this is kind of a surgical emergency. So unilateral testicle pain can be a torsion. It can happen in a younger population, but this is one of those testicular emergencies out there. So if you have extreme pain in the testicle, this thing is riding high and it's really tender and really swollen, you go to the emergency room and see if we can untwist it so that it gets its blood supply back and it doesn't die without its own blood supply. You will know this. This is very painful. And then, of course, testicular cancer. So I'm not going to spend a whole lot of time on this one. It's not as common as prostate, but it can happen. So check for lumps. Whenever I do an exam on a male, I always teach them a testicular self-examination to make sure that they can identify what's normal, so they can identify what's not normal. And guys will figure out how to do this relatively easily. Younger population in general. But if you find it early, it's got a 95% 5-year survival. It is a great cancer to find early because the vast majority of people do very well with it. And so let's check our nuts, right? Not on screen. But there is, I found in the Irish Cancer Society, this one, it's great. It's got 2 walnuts. And it kind of guides you through on doing a good testicular self-examination, looking kind of around the outside of the testicle, looking to see if there's any lumps that are on the outside rim, but also giving the testicle just a little gentle squeeze between your thumb and the forefingers to see if there's a lump on the inside. A lot of testicles will only have a lump on the inside, and you can't find it just by feeling the outside of the testicle. You got to feel what that sensation is on the inside, and you'll feel kind of like, why is there a rock, a hard thing in my testicle? It should give a little bit. And unless you have done this before, you're not going to know what's normal, so you're not going to be able to know what's abnormal too. So healthy testicle on the left, looking for those lumps either on the rim of the testicle or inside is a good way to do this. And if you find it early, you are in good shape. A little plug for a vasectomy. You just saw kind of like how the vas deferens comes out of the testicle and wraps back around to get the sperm for delivery. The swim team may have been cut, but the coach will never retire. It's a great vasectomy shirt one of my patients showed me. Again, this is what we do. It's very simple. We basically just disconnect the pipe so that the sperm can't go from the testicle all the way back out to the end of the penis. It's an office-based procedure. Local options here. I've done these for 27 years in town. Dr. Davis does these. Matt, I'm teaching to do them in the clinic too. So lots of options locally. Let us know, and your PCP can refer you over. Super fast recovery within a week, covered by most insurances. And if you don't have insurance coverage, then the Family Pact program in California will pay for these totally, like absolutely 100% covered. And it's a permanent solution, right? It's not something that like a condom. You're going to want to like just be done with childbearing and child development for the rest of your life. It's going to be a kind of a one and done procedure. So if you're done with your family production, then this is a good way not to have to take oral contraceptives or have your partner have to do her contraception forever either. And World Vasectomy Day is always I think the third Friday in November. So this year, November 15th. I'll give you a minute to digest that one. So a bunch of women in the wilderness lined up behind a porta potty, and they say, ever notice how it's mostly men who call it the great outdoors? And there's a sign that has men being able to pee anywhere. So this gets to the next one, which is penis. Right, so this is number 3 on the hit list here. This is going to be penis kind of like 101 from a men's health perspective. I always get questions about cancer, right? Penile cancer is vanishingly small. But the ones that do happen seem to have a predilection for human papillomavirus or warts virus. So with vaccination in our youth, kids in their preteens, we're getting these folks vaccinated for papillomavirus, so warts, cervical cancer for papillomavirus in women is a nice target. If we get papillomavirus out of the population, we have a chance at really almost curing cervical cancer. So in guys, HPV vaccine, super helpful at avoiding the relatively small risk of penile cancer, which is no fun. And also having your not transmitting a papillomavirus to your partner so they don't get cervical cancer. We can also have trauma to the penis, of course. There's something called Peyronie's disease, which can be a penile fracture. We'll talk about penile anatomy here in a minute, but you can overdo it and you can get some trauma and it can scar. And so you see on the bottom there in number C, you can have a fibrous plaque. And if it scars, then when the penis inflates, it's going to kind of curve. So if you have curvature when you get an erection, you may have some scarring, not all due from trauma. It can happen on its own, but this is something called Peyronie's disease and something that we do have some treatments for too. Obviously, you can get the penis infected. Right. So you can get if you're not circumcised, you can get a yeast infection in the foreskin, which can be kind of gnarly. That's easy to treat too. So if there's a superficial infection that you have, then that's easy to treat. And of course, as sexually transmitted diseases, those are infections that are going to travel up the urethra with exposure. So we need to be careful of things like chlamydia and gonorrhea and syphilis, which are going to be infections that affect this area. But the biggest question I get in my patient population, and granted, I have an older population with the exception of Bronco Clinic, but the biggest question I get is erectile dysfunction. So we're going to spend some good time on ED. All right, here's our banana. All right, let's talk about the physiology of an erection. This is a highly coordinated, very complex interaction of nerves and blood vessels. You remember those two things, nerves and blood vessels, all right? So erection starts by getting a nerve signal to increase the blood flow to the penis, all right? So there's got to be some sort of signal that says, all right, go ahead and open the pipes. Let's get some flow to this structure here and start the flow down there. So blood flow comes in, just like a catamaran. The inflation happens on these two shaft balloons. They're on the top half as you look down on the penis. They're called the corpora cavernosa. And if you look at the picture on the left, these things are generally not full of blood to start with. And as the nerve signal opens up those arteries, those red things that are in the middle, the cavernosus artery, and then the dorsal ones, the blood flow will start to get into this, this area. Now, notice that the arteries will bring blood to the penis and the veins bring it back from the penis. But do you see the orientation of the veins? They're around the outside of the catamaran balloons, all right, the corpora. So as the blood fills these two balloons, it will compress the veins on the outside, and so there's less flow going out and more flow coming in. Ergo, you get a balloon, right? More blood going in than outflow. You've got basically a balloon animal, right? So you've got a firm erection, and you can make anything you want out of the balloon animal, like Gru here. But that's the physiology of an erection: nerve signal and blood flow. Just remember those two things. So what could possibly go wrong, you ask? So bad nerve input, right? This is our first one. So what happens with nerve input? Well, you've got to have enough sex drive or libido to start the nerve signal coming from kind of the brain. So there's lots of areas of the brain. Here's a quick diagram of kind of like where all these centers are in the brain, for all our neuroanatomy buffs out there. What kind of things can like destroy it? Well, brain damage, stroke, organic brain syndrome, trauma. Sure, certainly those things could do it, but also the function of the brain. The structure is fine, but the function's bad. We're under a lot of stress, anxiety, depression, a lot of mental illness. You know, it's said a lot of the time that sex is like 90% mental. This is the mental part, right? This is the nerve input piece. It's just bad timing, right? It's like you or your partner is just not, you know, the nerve signals aren't going to, you know, be, you know, aligned there. You can, of course, have a nerve damage, right? So diabetics have a lot of peripheral nerve damage, for instance. And so they can get nerves that go to these arteries and just aren't getting the signal. Stroke patients, MS patients, spinal cord patients, right? Nerve damage directly can cause this. Meds. There are a whole bunch of medications that just diminish the nerve input to the penis to start an erection. And there are a lot of the medicines we use for a lot of things, right? Meds that can kind of like help the stress and the anxiety and the depression can actually make the erectile dysfunction worse. So you got to walk a real fine line here. Meds that treat blood pressure, treat pain, treat neurologic things. And then, of course, meds that really aren't meds, but are like, you know, drugs. So, you know, opioids, amphetamines, alcohol. You know, we don't have a whole lot of heroin, but a lot of those recreational drugs will cause a nerve problem, and you don't get the right signal down there. All right. And then low testosterone too, which we'll come back to in a little bit here too. So bad nerves, right? That's one of the problems with erectile dysfunction. All right. And now you know the other half of the equation, right? Bad blood flow. So the blood flow is bad. Again, diabetics get a double hit here. So they have poor blood flow and bad nerves. So lots of erectile dysfunction in diabetic patients. High blood pressure. If the pipes are constantly under a ton of pressure, then they may, you know, have problems with leaking or not getting the amount of blood you need to the penis to start. Smoking. Smoking gives you horrible blood vessels. So smoking is just going to destroy the blood flow getting down to the penis for an erection. High cholesterol. So again, if you have a lot of plaque buildup, same thing as high blood pressure. The pipes just aren't as healthy as they should be. They're not as flexible. They don't get the flow down there that they need to. Age. Well, as we age, the blood vessels have less flexibility. They're stiffer. They have more cholesterol plaquing building up, and they have less nitric oxide. Nitric oxide is a key component of vascular health for flexibility and distensibility too. So that gets older as we age. We just lose nitric oxide pathways. And then again, here we go, low testosterone too, which we'll come back to. All right. So bad nerves, bad blood flow. What do we do about it? All right. You're already thinking like, okay, how can I treat both of these two different things? Let's talk about better nerve input, right? And better blood flow. All right, better nerve input. Duh, stop the bad things that are getting the nerve input, you know, worse. And yeah, alcohol can be kind of an icebreaker and it makes you a little bit more relaxed, but if you overdo it, you're going to start getting bad nerve input and have erectile dysfunction. If the meds are a problem, we'll need to stop some of the prescription medications. So again, talk to your provider on whether the meds are doing you a favor or whether they have side effects, because we have lots of different options to treat things with prescription medications. Try to get the stress and the anxiety and the depression under control as best we can. Easy to say, hard to do. We can treat some diabetic nerve issues directly with different medications, and then we may end up treating low testosterone if it's there. All right. Other kinds of things, nerve input wide. I've heard a lot of patients bringing up, like, what do you think about peptides? Too early to tell, but for those of you who know what peptides are, they're little tiny molecules that go to different places and do different things. PT141 is one of the ones that has had some luck in women and has some traction in men. Not a lot of great studies, but it goes to the brain and it stimulates kind of the melanocortisone kind of pathway up there and can help with some of the nerve input in certain individuals. Not ready for prime time, expensive, and kind of, I wouldn't say experimental now, but we just don't have enough data yet. All right, let's talk about better blood flow, right? So obviously treat cholesterol, treat blood pressure, stop being bad to your blood vessels, make them happy, and they'll get flow to where you want it, right? You know, again, treat your diabetes so that the vessels are happier down the road. And then again, if we have some low testosterone, that may help with blood flow as well. You can increase the flow to the penis directly. Some of the over-the-counter supplements contain nitric oxide that can make a difference. You've got prescription medications that will also try to push more blood into those balloons. Try to make the tissues a little bit more distensible. And sometimes you may end up using other things like PRP or shockwave to try to get the balloons a little bit more flexible and like able to kind of accept that input blood flow. And then, of course, you can actually directly dilate those balloons by putting a needle in there for an erection. Not a whole lot of guys want to do this. But, you know, if it looks like push comes to shove, then we have medications like Trimix and some of the other direct vasodilators that will open up those pipes and get blood flow down to the penis. All right, so let's kind of dissect those a little bit. Over-the-counter meds, how they work. A lot of them will take this molecule called DHEA, and it's kind of like the precursor for testosterone way down the pathway. You see the arrows. So that's a proto-testosterone. So if you're low, then you might be able to kind of move that up with over-the-counter meds. Some of the other over-the-counter meds will try to improve that nitric oxide we lose as we get older. Arginine and citrulline are some of those. Making the nervous system work a little bit better. Ginseng can do that. Yohimbine can sometimes increase over-the-counter blood flow. These are all over-the-counter medicines. There is a huge industry that's related to this for trying to get these medicines to work. Antioxidants can make a difference in many, 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 many others. So what do I tell my patients about over-the-counter meds? If it's not going to hurt you for some reason, it's worth a try. But you just don't know unless you try these things. It can affect probably your pocketbook more than anything else, because these things are not cheap. If they work, great. Could, use them as long as you're not causing a problem. But they don't work for everybody. Success rates vary all over the map. So it's not hurting. Try it out, see if it works, and then that may be your foundation to start with. Now, what about prescription meds, right? The little blue pill that changed the world, right? In the late 80s, this took the area by storm. So Viagra, Levitra, and Cialis, all of those are prescription medications we end up using. And then you've got all of these kind of Viagra knockoffs that are online now. You type erectile dysfunction and over-the-counter meds, you end up with a whole bunch of stuff. And so all of them improve blood flow to the penis. They help to augment or dilate the flow to the penis, but they don't cause an erection. All they're going to do is augment what's on the way. All right. So there's a misperception for a lot of my male patients. I'm like, okay, I'm going to pop a Viagra. I'm going to get an erection for sure in an hour. Yeah, not unless the nerves are sending the right signal down so that the blood flow is going to get to the right place, right? These guys all improve blood flow. They don't do anything for the nerve piece. So you're going to get an erection. It's going to make it firmer, better for penetration, better for completion, but it's not going to cause one, right? You got to have something to start with to improve the blood flow to get blood down to where it's most effective. Now, You can do other kinds of things other than, prescription medications. There's negative flow. So you basically pull a vacuum on the penis. So you improve the blood flow, get to the blood flow out, and then you kind of snap a ring around the base to hold it in there. These things are called tension rings. They block the outflow. You can also do the injections we just talked about, which may make the blood vessels a little bit more flexible, a little bit more distensible. PRP, which is platelet-rich plasma, is your own blood spun down and then getting this platelet-rich part of the plasma and then putting it back into the penis. This isn't as needed. This is a therapy that is done, once or twice a year to try to help the blood vessels get a little bit healthier. Not super great data on this, but, at least it's your own serum that you're using, and you might be able to make those treatments a little bit better with injection. And then, of course, directly injecting the penis at the time of need with a directly delivered medicine to both of those balloons to dilate those things. Again, pretty aggressive, but you know what? It works in a lot of patients. So these guys, of course, will cause an erection, right? Because you are directly improving blood flow to the penis and holding it there, right? So these guys will cause an erection, whereas the Viagra class of medications and the over-the-counter knockoffs will augment an erection that's coming, all right? So that's the erectile dysfunction piece of this one. So now we're in the home stretch. We're going to talk about testosterone for a little bit here. Remember, it's produced in the testicles. It's a hormone that's responsible for puberty. So we all went through the change in adolescence. We got hairy. We are voice deepened. We started building muscles, right? We had sex drive. So all of those things are related to the testosterone surge that we get when the testicles come online. And as you get older, it decreases naturally. So you take a look, when we're in our 20s, the testosterone's on max flow, and then it slowly diminishes over time as we get older and older. So how many guys have testosterone deficiency? It's not as many as you'd think, and it's not as many as the press would like you to think as well. About 2% of men overall actually have testosterone deficiency to a point where you actually have to replace it. It's more common, like I said, as you get older. If we all make it to 80, we have about 50% incidence of low testosterone. So 2% over the entire age range, but the older you get, the more likely you are to end up developing this. More common in diabetics and obesity. It's just the way that the hormones work in the body for this. And you'll read a lot about okay, I think I have low T. What are the symptoms that we look for as providers for a patient who has testosterone deficiency or low T? These are more specific. They're not 100%, but if you start logging these things up, then you're more likely to have a testosterone deficiency and have low T. Low libido, right? Sex drive in the brain with the nerve function we just talked about. With erectile dysfunction, you start losing the hairiness that we have both in the body, around the genitals, as well as beard. Hair growth on the top of your head, not necessarily an issue. We may lose the hair on the top of our head. It's called androgenic alopecia. We may lose that because we have testosterone. So top of the head, no. Beard, body, yeah, maybe. Loss of muscle mass and strength, not just because of age-related change, but I got, a 40-year-old guy that comes in and he's like, hi, I'm just losing a lot of strength. I'm working out at the gym. I'm just on a deterioration here. I'm not building muscle strength when I really should be at my age. Since you can't, exercise and your muscle mass is low, then you have low T. So some of the estrogen that your adrenal glands produce can kind of kick in. And so you may have a shift and you have central, obesity. More fatigue, more depression, difficulty sleeping. Now, these are pretty non-specific, but you start adding them all up and you have more of a likelihood of having low testosterone. Because testosterone builds up bone mass, if you have a deficiency of it, you may actually get osteoporosis. Remember that 15% of the population who have osteoporosis are guys. It's not just a women's disease. So if you have low T, you're likely to end up with some low bone mass or bone density as well. All right. So we all know the statue of David, right? That's a, a 20-something, Greek depiction of testosterone. And here's what you look like with testosterone deficiency, right? So the stuff we just talked about. The testosterone on the brain's effects with mood, depression, the increased belly fat, the libido, the bone risk, the low strength. And if you have low testosterone, contrary to popular belief, you may actually be at increased risk of heart attack and stroke. All right, so how do we make the diagnosis? It's all about blood testing. So if you have that constellation of specific symptoms, you ask your PCP, and in general, a low testosterone on a morning blood draw of less than 300 is not a clincher, but it's very suspicious. Now, why do we get a morning draw? Why don't we just do it in, the afternoon or something like that? The levels of testosterone vary over a 24-hour period. And if you're a young man, you see that midnight to 6 a.m. Graph is just the super spike of testosterone. In older guys, it's a little bit more blunted, but the levels do vary over time. And that big surge in the morning is usually the highest. And what do we get in the morning, right? So we get this thing called nocturnal penile tumescence. You get morning wood because that testosterone is going way up in that after midnight time frame. So if the testosterone is working, then we want to try to catch it at the right level, which is, 8 to 12 a.m. So that's when we want to get it in the lab. Generally, we'll check 2 readings to be sure. Some of this is just as a double check to see what's happening. And the other one is if we're going to start somebody on replacement dosing, the insurance companies usually like to have 2 separate readings on 2 different days to pay for it. All right. Now, we just talked about what testosterone diagnosis for low testosterone is, what might not be low testosterone. All right. So, here's our graph again. I look at this happy guy here. He's got all these things that are good for testosterone. But if you take a look at each one of these things individually without the constellation of them, it may not be low testosterone, right? You can imagine somebody that has low energy, low endurance, and low physical strength alone as not having low T and may not need to be treated. Maybe they're just a couch potato. Poor memory. Maybe the person is depressed. Maybe they're drinking too much alcohol. Maybe their focus at their job is because they don't like their job, or they're not doing well at school for a lot of different reasons. Maybe they're depressed because their wife left them. So there's lots of reasons why you may have these things that not are low T in and of themselves. So especially if there's just one of these things, it's certainly, we want to talk about it and see whether we want to test for it or not. But just because you have poor memory doesn't mean you have low testosterone, right? Just because you're depressed doesn't mean you have low testosterone. We want to try to look for those specific features where it is much more obvious there. Now, how do we replace this? Oral pills generally don't work very well. All right. The liver just chews them up. You don't get a whole lot delivered to the rest of the body where you want it. And they can be kind of liver toxic. So you really need to kind of bypass the intestinal tract that goes to the liver. So that means you're going to do something outside of the gut, either a patch. I don't think we have andro patches, testosterone anymore in the US, but you can get it through the skin. Most folks do a transdermal gel, a little pump of some gel you smear onto the skin. You can do sublingual drops, not really great absorption that way either. You can do an injection of this stuff every couple of weeks with a depot. Unfortunately, testosterone oil is really thick and you have to use a fairly large gauge needle. And a lot of guys don't like, sticking that big needle in a muscle group every 2 weeks for the rest of their life. You can have some pellets injected. These are depot forms every couple of months, so maybe better than pellets. Better than injections, the pellets might be, but the vast majority of men who have testosterone deficiency who get replacement are on a gel, or on a topical gel that you smear on. And it's very safe, very effective. Some people just don't get it through their skin. We have to move to injections, but I always start with androgel or a gel product when we start replacement dosing. And we're not going to go through this slide, but again, here's lots of different brands out there from very novel ways to get it past the gut, like squirting it in your nose or doing a little patch on your gum. Honestly, you know what? Gel is so easy. Each morning you do a couple of pumps and you're done. So vast majority of guys are doing this transdermal gel. Now, what do you have to do to monitor it? All right. This is not a free ride here. You have to monitor the things that testosterone does. And so we don't want to get the blood mass too big. We don't want to drive a prostate cancer, right? So there's good data that shows testosterone replacement does not cause prostate cancer, but if you have one growing, it might accelerate it. So you want to be careful at screening for prostate cancer and doing the appropriate management here, and working with your PCP or your urologist to do this in a safe manner, right? So, it's just like, snake oil back then. Do I have low T or not? Can I get treated for this? And just like the snake oils in, the 1800s, a lot of this direct marketing to people of like, yo, you have low T, you need to get your T checked. I'm going to, sign up for this online, replacement program. Lots of this is direct marketing. A lot of the products you're getting over the counter or that have a lot of hype, but not a lot of goodness to them. They aren't rigorously standardized or testing, aren't FDA approved for this purpose. Some of them are costly. You just like scan the internet and you're like, wow, this is going to be kind of pricey. So get a good diagnosis and try to avoid some of the pitfalls of kind of the snake oils, because we don't want you to get something that's, dangerous to you. And the over-the-counter stuff and the things you get online can be wildly subjective. You got somebody saying great things about it, and that may not be you. So lots of pitfalls there that you want to avoid there. Okay, so just be careful, right, with this. Talk to your PCP about it. They're knowledgeable folks that they're going to kind of guide you in the right direction. All right, so this wraps up our 4 hits for specific men's health. Again, kind of a wrap up. Cholesterol and strokes and heart attacks are going to kill us first, guys. So get those things looked at, screen appropriately. We're going to try to avoid all the cancers we can, including colon cancer, getting screened at age 45 and on. We're going to look for prostate cancer with whatever, choice you want. Skin cancer, huge issue. That's going to be probably next month. We're going to do a little primer on skin cancers. But men specific things we've talked about. So again, we got prostate, we've got testicles, we got penis, and we got testosterone. So hopefully this was helpful, kind of a whirlwind tour through men's health. And we will, I think, entertain some questions.
Thanks so much, Dr. Brown.
I'm going to stop sharing here in a minute. Hold on, if I can. There we go.
Dr. Brown, there is a question in the chat. It's what is it like finally being at an age where you're perhaps experiencing some of the same issues / testing for some of the same things as your aging patients? Does it influence your approach?
So, I think this question gets at the continuum. Right. So you've got, you look at dad and granddad and you're like, oh my God, I remember dad getting up, at night and pee all the time at nighttime. And you're like, God, I'm getting to an age now. And when we're in our, 20s, we're invincible, right? We can, there's nothing we can't, tackle. And so we do a lot of stupid things, right? We get into a lot of accidents, and accidents kill a lot of us too in the younger age group, because we just have no brain associated with ourselves. And then you kind of get into your, your family bearing years, in the, your 20s, 30s and 40s, and you're building career and you're super busy and you've got soccer things to do and throwing pitch, with the son, and you're just trying to kind of keep up. So we limit our entry into kind of the healthcare arena. And so, those times are really busy. And then we start getting into our 50s, right? I'm going to be 56 this year. So we get into our 50s and we start kids are starting to kind of get, to college or out of the house. And we start looking, back and going, oh my God, what happened to me? I'm like, I'm getting grayer, right? I'm losing my hair. All these things are accumulating. And, there's still a lot of things we can do to kind of improve your function and to avoid bad things. And so, as we get older, we need to just kind of take charge, just like we did when we were starting families and just like we did when we were starting our careers. Take charge of your own health now and say, all right, I'm the priority, and start doing the things that will keep you around to see, your kid's graduation.
Dr. Brown, I have a question. So a lot of these disorders that you mentioned, erectile dysfunction, certainly anything like cancer, or even like, benign or BPH for your enlarged prostate, which causes you to get bad sleep and wake up at night. I think a lot of those things can definitely impact patients' mental health or mental health. And could you talk about that and maybe some of the resources we have here at the district to not only treat the problem, but treat the consequences of the problem, which is the health issues.
Yeah. Mental health is a huge issue, and we don't like to talk about it, right? The previous generations have taught us, like, you know what, just buck up, get through it. You're strong. You're weak if you have, problems with anxiety or depression. And it's bullshit. It's BS. Okay. So this is real stuff. Men are much more likely to complete suicide than any other gender, right? Like, women don't like shoot themselves out in the shed. And so this is a real thing. When you start feeling depressed enough to think about, bad things, this is a big red flag for us. And so, accepting that, like, this can happen to you is number one, right? So realizing that you want to bring it up to your PCP. The primary care provider can end up being your entry point into therapy if it looks like you need something. But it's the dialogue, it's the discussion back and forth between you and your provider to kind of see where you're at. Not everybody that comes in, to my office who's depressed leaves with a Prozac prescription. Right? They may need counseling. They may need focal therapy for talking through this kind of stuff, or looking at behavioral modifications or cognitive behavioral training. So there's lots of things other than getting a prescription on your way out of the office to kind of treat these things. Granted, you need meds sometimes, but we have lots of counseling options in the community. Mental health is always difficult in rural environments, but we've got, the county, we've got private providers, we've got district providers that can do counseling. We've got a great PT, OT department, physical therapy and occupational therapy, that can kind of work on some cognitive behavioral therapy, which is super good for insomnia and some other cognitive stuff. So lots of resources, even locally in this rural environment. Telemedicine has taken off. So if you, don't want to, talk to somebody face to face, you feel more better on Zoom or a telemedicine visit, lots of options out there to be able to do a telepsychiatry or counseling visit at home. You're not going into, somewhere where maybe somebody knows you or you're uncomfortable.
Yeah, absolutely. I certainly want to echo, and I think your talk illuminates that these problems are common and they can be really distressing. And the best thing you can do is go find out what your options are to treat these problems. And those treatments could be a pill, they could be therapy, they could be a surgery or a procedure. But I think it's empowering as a patient to know what your options are. So thank you so much for shedding light on all those issues. Yeah. And Bart, I don't think, if we have no other questions from YouTube or the chat, we're right at an hour. So Dr. Brown, thank you so much for your time. And as Dr. Brown mentioned, he's going to be giving another talk on skincare here in the next month or two. So be on the lookout for advertisements regarding his next talk. Thanks so much, guys.